So delighted that Dr. Tully and Demef have been able to join us. I think they drove down from El Centro, huh? So their talk is on cybersecurity for healthcare. I alluded to it in the opening comments. So the floor is yours.
Thank you so much.
Thank you so much.
All right, good morning, everybody. We'll get started here. 49 slides may have been a little bit ambitious, but we'll give it our best shot. My name is Jeff Tully. I'm an anesthesiologist here on campus. My partner, Dr. Christian Demef, did in fact drive from El Centro 2 o'clock, 3 o'clock in the morning after working all night to be here with you today, so that's dedication. We are the co-directors for the UC San Diego Center for Healthcare Cybersecurity. So we are clinicians first, but we're also cybersecurity researchers working computer science. And we are really interested in understanding how cybersecurity interacts with the care that we deliver to our patients. So for this talk, we're going to ask you to buy into the premise that not only is it important to protect our patient information and data, but it's also important to ensure that the tools and technologies we use to take care of patients in the clinic and in the hospital are available and not disrupted by things like ransomware attacks. And so our center is a multidisciplinary center, very fortunate and privileged to have Dr. Rao participate in many of our projects. And so that's kind of what we look to do from a research standpoint. You probably also don't need to be convinced that ransomware attacks are a problem of increasing incidence and impact in healthcare delivery. Significant financial, regulatory impacts, but then some of the work that we've done shows that there are significant and measurable disruptions to patient care delivery as well. We were able to do some work. It's very challenging to measure the impact of a ransomware attack on a hospital while it's occurring because many of the systems that we use to collect care quality data are themselves not available. So one of the things that we did is take a look at what happened to our facility, UCSD and associated hospitals, during the Scripps ransomware attack of 2021. And we did see a significant increase on our clinical resources, our staff, from the standpoint of the emergency department in particular in this paper, that really kind of created this idea that ransomware occurs in a healthcare ecosystem and the institutions can be affected even if they are not directly attacked. And so that's why it's important for us to strengthen the resiliency of our national healthcare infrastructure. And we've been very fortunate over the last year to be awarded a contract from the new agency ARPA-H. So for those who are not familiar, the Advanced Research Projects Agency for Health is a kind of independent entity within the NIH that has existed for a couple of years and really looks to fund kind of the same moonshot style, high risk, high reward work that DARPA and other ARPA agencies are known to fund. And so we were in one of their inaugural programs, which luckily enough for us focused on healthcare cybersecurity. And we have a program that seeks to increase the resiliency of hospitals across the country to ransomware and other cybersecurity incidents. Our work is a little bit different from the other performers in our class because many of those are focused on very technical solutions that are incredibly important to secure things like hardware of medical devices and other kind of lower level technical work. Ours is really a patient-focused, clinical delivery-focused, practical project. And so we have three main goals we're going to talk about and share some of our initial research for you on. The first one that Christian will mention in a moment is it's of interest to us to be able to more quickly identify hospitals that are affected by ransomware attacks so that we can make resources available to them. Number two, we really want to improve clinical ability to respond and deliver care during the disruptions induced by these types of cybersecurity incidents, and I'll talk more about what that means. And then we are investigating ways in which we can develop systems that can kind of be used to stop the bleeding and restore some level of technical function to these hospitals that are impacted. So we've come up with pithy names for each of these technical areas or areas of the project that we're talking about. And that first question of where are ransomware attacks occurring? How can we rapidly identify them? We have punnily named it ransomware, question mark.
I'm just going to level set for a minute for those folks in the room that might not be very familiar with cyber attacks, specifically ransomware. But what we're focusing on ransomware is an attack on the availability of critical healthcare resources. So ransomware is a class of malware or malicious software. It's often deployed by very ill-intending hackers, adversaries, usually outside of the United States. And they target healthcare across the globe. But they first will get into a network, they'll do some reconnaissance, and then they'll stealthily deploy some malware, this ransomware, to various parts of this critical infrastructure, and then they'll kind of trigger the trap. It will encrypt these various systems, generally making them unavailable for use. And if you want to restore those operations, then you have to pay some large ransom, often in the source of cryptocurrency like Bitcoin. And it's no longer the case that it's $100, $200 to get your hospital back. Now we're talking about sometimes tens of millions of dollars. These attacks last not days, hours, or days, but now we're lasting weeks to months. And this is not very obvious at first glance. Why would it be difficult to detect these attacks? It really isn't. What it is a policy and culture problem that we have around cyber attacks on institutions like hospitals. When a hospital is hit with ransomware, they don't want to report it. They have to have certain regulatory reporting requirements for agencies like HHS OCR if they have a breach of protected health information. But what is often the case is that the first public PR story out from a hospital that's been ransomed is we're having some technical issue. Please bear with us. This is particularly difficult for researchers like us, and we'll talk about why we want to discover this more quickly later. But what we wanted to ask the question is, can I detect a hospital's under ransomware attack without them ever having to tell me? And how close to the initial onset of infection can I get? The idea is that if we are able to detect it very quickly, we can reach out proactively with resources. We're going to talk about what that means at the end. But a lot of times, hospitals there's no flag outside of a hospital that they'll take down when they've been hit with ransomware. There's no obviously measurable marker of this. So we actually have to infer that a hospital has been ransomed. So how do we do that? Hospitals are very, very noisy on the internet. What do I mean by that? They're like large entities. They have email servers. They run a variety of different clinical applications. They often have many IP address space. If you know where to look, you can find the digital presence of hospitals, and they're frequently beaconing and communicating with other things that we all of a sudden hear nothing from. It's not that we're measuring a loud attack. We're measuring the absence of their normal operations, which in a sense is digital silence. Can we detect that? We use a variety of signals to do so. Things like their standard web services, email, DNS, et cetera. We also measure healthcare-specific applications, looking at things like the electronic health record and the ability for them to share records between institutions. We monitor social media. We do some cool stuff with beaconing using the time protocols, et cetera, so that not only are they failing to reach out to others, but they're failing to reach out to us, and we can measure that. The whole idea is to build a model in which we can understand the regular digital behavior of a hospital, and when it deviates from normal behavior, flag that for some type of abnormality, which could be anything from a hurricane, for instance, or a ransomware attack. We've had some success in looking at retrospective data around this using one of our data sources. This is the Scripps ransomware attack that impacted San Diego for close to a month. Using these standard protocols, you can see that they drop off, right, the ransomware attack. And they're actually restoring at various intervals, and we can measure those using internet measurement techniques that are pretty standard. We scan now, as part of this project, over 6,000 hospitals a day, multiple times a day. We're collecting a lot of data. And now we're trying to operationalize that and scale that up into a database. Eventually, it will be a dashboard where you could see essentially in real time what the digital health, if you will, the digital pulse of hospitals across this country is, and be able to do something with that information. One of the most successful protocols we've had in monitoring is something called FHIR. If you work in this space, you know this is a increasingly common and actually mandated protocol for health systems to communicate not only with other healthcare facilities but also with patients. So if in your pocket you have a smartphone, and on that smartphone you have a application like MyChart, something that will share data from your hospital with you, that's communicating over the FHIR standard. Hospitals will host FHIR endpoints that we can, per the protocol itself, monitor its availability. So that's kind of one of the examples. We weren't just successful in retrospective data. After the creation of our system, we were successful in proactive detection of ransomware. Anyone from the Chicago area? No? All right. Well, West Coast is the best coast. Lurie Children's is a children's hospital in Chicago. It was ransomed earlier on this year. Our system detected it 6 hours before they put out a public statement stating that they had been infected. Actually, they didn't even say it was infected. They just said their phone systems were down. I'm sorry it's taking so long to get in contact with us. This data is quite interesting. Please no one take a picture of it. It turns out when you build a system that detects ransomware attacks and the unavailability of healthcare systems, you also pick up some very interesting things like CrowdStrike that aren't actually ransomware events. But if anyone had their life disrupted by the CrowdStrike update that happened earlier on this year, yeah, I see a lot of really angry faces. I'm not sure if you guys were flying. This is us monitoring Fire API unavailability of hospital systems in the United States during CrowdStrike, and you can just see a very significant signal here. Not only that, we were able to determine where those hospitals were, and then if you look at the small part of the diagram on the right there, you can see we are able to detect how long these hospitals were impacted by CrowdStrike. We are scanning lots of Fire endpoints. It's just one of the signals that we use. This is an interesting angle that we're taking as well, which is, as I mentioned, you can proactively reach out to a hospital, knock on their door, and say, "Are you up or down?" using internet measurement techniques, right? That's an active us reaching out to them and seeing if they respond. We're also looking at a variety of signals that are them reaching out to us, and when they fail to do so, that could be some signal. There is the network time protocol. It's a standard protocol that can basically sync clocks among computer systems. We host an increasing amount of NTP servers on the internet. We know when hospitals are reaching out to us to ask us for the time, and in this graph in the left, you can see in one particular hospital system that got hit with ransomware, on the order of about 4 or so times an hour, they would reach out to us for the time. Well, when they got hit with ransomware, they stopped asking us for the time. This is just another example of, again, instead of an active approach, it's a passive approach in which they come to us, we measure those types of things. I'm not going to get too much into this, but if you are fascinated by this topic, I highly encourage you to go on social media, go to the medicine or emergency medicine or the nursing subreddit, for instance, or go on Twitter and read the comments of nurses and doctors and patients being taken care of at hospitals that are under ransomware attack. Some of these things are, these stories are harrowing. They are 100% reinforcing of our initial hypothesis that these types of attacks really impact patient care. All right, and then of course, it wouldn't be 2024 if we didn't talk about applying machine learning techniques to this. I mentioned building standard models, deviation, et cetera, to help detect a difference between whether or not it's a hurricane versus a ransomware attack, et cetera, is the goal to assign a probability that a particular signal that we're either seeing or not seeing can be attributable to a particular outage. All right, on to the second part of our work.
So the idea with that first tool is that if we are able to identify a hospital that may be affected by a ransomware attack, we can reach out more quickly and intervene with the resources that are going to help to take care of patients. And the second aspect of the work that we call the tome essentially submits that our status quo with respect to downtime, and Christian mentioned some of these attacks last for days to weeks to even a month or two at a time, is woefully inadequate for the heavily specialized care workflows that we use to take care of patients with conditions like stroke or heart attacks or sepsis that are really time dependent. So it's their outcome is directly proportional to the amount of time it takes to deliver the definitive therapy. And if you are a clinical member of the audience, you know that our downtime forms are often very low data density, very, very hard to use at scale. And so one of the things that we're seeking to do is develop tools that can be used more effectively, that are more clinically oriented to the unique types of disruptions induced by ransomware attacks to help take care of patients. One of the ways that we kind of generate hypotheses is by using clinical simulation. And so what we do is we take folks, we put them into situations where they don't have access to the tools or systems, things like the electronic medical records, laboratory results, or imaging, and kind of see how that changes their mental models with how they apply direct patient care. As part of this work, we've done a couple of in situ simulations. So we took actually one of the UCSD family medicine clinics over. We brought in a team of completely unsuspecting clinicians, nurses, MAs, brought in some standardized patient actors, and then did a full kind of downtime exercise. And that was very interesting. If you want to scan a QR code there, there's a kind of unique video summary that talks about some of the lessons learned from these folks who have not ever kind of practiced a cyber attack downtime before, do not know that they have their emergency procedure kits for this type of incident and are really kind of underprepared for this in general. We're doing some more conceptual work to sort of identify interdependencies between various services and technological platforms to really kind of game out in a deeper way some of the anticipated disruptions, and then taking that information and putting it into a clinical context with kind of specialty-specific ransomware playbooks. And there's really a lot of interdependencies, obviously, between all of our various services, and understanding that, kind of distilling that into meaningful action, downtime procedures, playbooks for these types of situations, we suspect, in addition to the next resource that Christian will talk about, will lead to improved patient care during these increasingly occurring types of events.
And I just love that, because the tome is really filling a gap that doesn't exist. We, in many hospitals, will have very detailed ransomware technical playbooks where we know what systems to take offline, what priorities from stopping the infection, doing forensics, et cetera. But the clinical teams are left completely to fend for themselves without any guidance. And so our intention with this tome is to say, if you're a cardiologist, turn to chapter 10 if you get hit with ransomware, and these are the patients, the specific patient populations, and what you should focus on so that those patients have a chance to survive, especially when minutes matter and things like stroke, heart attack, and sepsis. So believe it or not, no one's ever done this work. It's incredibly resource intensive. You have to do detailed workflow analysis at the individual clinical service level, at an entire hospital, and then to map that in those interdependencies to the technology they use every day is a gargantuan task. And our plan is to release this resource next year as a free public resource. We hope it becomes the next de facto standard, international standard that hospitals will use when they're hit with ransomware. And really the audience, again, is clinical folks, nurses, doctors, et cetera, instead of technical folks. All right, so if we are successful in any of these things, I will have, be very, very happy. And we've shown some very promising results in all of these. But there's somewhat of a theme. Find the infection as quick as possible. Stop some of the bleeding, for lack of the metaphorical bleeding, by giving the folks that have been hit with ransomware a guide to safe patient care during ransomware attacks. But then the last one is a play on a classic kind of theme in a lot of defense agencies, which is if the hospital is not functioning, what can we bring to the hospital rapidly to help restore some of that lost clinical care? And we call this last part crash carts. If you're familiar with clinical medicine, someone goes into cardiac arrest, they say, go grab the crash cart. This is a literal cart that has some life-saving equipment on it. We're using that kind of metaphorical crash cart. So restore the technology. The big question is, if a hospital's been hit with ransomware, and they're on paper downtime, and it's chaos, and people can't communicate, and care is taking much longer, they're missing diagnoses, they're not applying medications in a timely enough manner. What technology and what types of technology and how much and where would be able to restore enough clinical operations to the prior attack state that would increase patient safety? So in some ways, we want to build that crash cart. Imagine something like a national strategic stockpile of healthcare technology. We have a strategic national stockpile of vaccines and other types of antiviral medications stored on various locations around the United States. But imagine now that technology is we're so reliant on it to deliver care, it's almost as if it's as important as medicine itself. Therefore, when it's gone, can we bring it to them? And so our goal at year 2 is to basically have built a rapidly deployable replacement healthcare IT stack for a 20-bed emergency department. This is believe it or not, this is absolutely challenging engineering effort for many reasons. But the one I want to highlight to you is that we would be deploying such a system to a hospital that is under active cyber attack. The vulnerabilities that system had that prompted their infection may or may not be present in our own system. So in some ways, you're designing not just a replacement hospital system you can put up within a couple hours, very hard to do, but it has to be resistant or resilient or hardened enough to avoid the infection spreading to your own. So you're operating in a hostile environment. We can't use any of their existing infrastructure. We've done lots of interviews with places that have been ransomed, and they don't want us to use their internet. We can't use any of their switches. We can't use any of their physical links, that we can't use their telephone systems, and we can't use any of the core systems that they are then trying to restore. So in some ways, we have to bring whole cloth our own systems. This is, again, I mentioned a very classic type of approach, which has been deployed by many DoD systems, et cetera, but not to this level, which is that for FEMA, for instance, they can build a field hospital and it's all their own technology, it's all their own people. They don't go into a hospital that's been impacted and restore those operations for those folks there. We've been doing a lot of interesting work on the internet backhaul. We recognize if we're not able to use the internet at that hospital and we want to be able to do this at, for instance, a rural hospital in Idaho, what other options do we have to provide rapid internet? We are exploring things like satellite, cellular, et cetera, as reliable backhauls for these types of hospitals, and doing interesting work like which hospitals would be covered by which modality and would it be able to provide enough bandwidth to support things like radiology, which is very resource and bandwidth intensive. We can't use wireless in many ways because their systems, we can't use any of their APs, their access points, and also that they are going to be working to restore that. And if we deploy a system on the same spectrum as their Wi-Fi, we're going to be hindering in a lot of ways their recovery. So we had this interesting dilemma. How do we then get all of our replacement laptops and medical technology on a network? And so we are deploying CBRS private cellular. So we basically deploy our own private cellular networks rapidly into these clinical environments, which in some way helps isolate us as well from some of these more hostile network-like things where we don't get infected with ransomware. But it's not just that. I mean, we're going to have a toolbox of things that hospitals that have been ransomed can use, and sometimes it's just going to be good old, we're putting Ethernet down a hallway if we can, or we're using point-to-point Wi-Fi and doing a lot of experiments to see how feasible that would be at scale for certain clinical environments. We're tackling problems like how do you get access? How do you have, if your hospital has 10,000 employees, how do you get them all passwords and usernames? When there's no help desk. So we're really relying on physical authentication instead of things like traditional passwords and multi-factor authentication. Like these are the logistical problems that you have to think through in how you're going to deploy your system that really clash with reality. And so we're thinking about this from a really holistic way. I'm not going to talk much more about this other than to say, again, we're not only just doing the conceptual work, we're doing a lot of the experimental work. So this is the cellular coverage of hospital facilities in the country. We're doing Starlink satellite testing in different environments that would be next to hospitals, et cetera. So I'll stop right here. Here's some of our experimental data in a real emergency department using our private cellular network. I'll stop here and just say that we also want to host a lot of our services in the cloud. So if we can't host it on-prem, we're going to provide that backhaul and bring our own electronic health record to the show. But there are usability issues. You can't give a nursing staff or a physician staff an electronic health record they're not familiar with. So in a lot of ways, we have to host all of the electronic health records in the cloud. And if you're a Cerner shop or you're an Epic shop and you're comfortable with one particular software, that's what we'll deploy in your instance. And I think we'll stop there. Sorry for a little bit of the anticlimactic end, but this is not only a link to our website, but we are hosting an academic symposium here on campus at the medical school on November 20th and 21st. If you're interested in learning more about this and getting much more detail about this, here's a registration link, here's our email, and we're again very grateful for the opportunity to speak to you today.
Time for some questions?
2 minutes early, nice.
Larry?
Harinath Garudatri from QI. So if you imagine this kind of features deployed system-wide, do you have any idea of how much cost we are adding? Because we talk about $4 trillion per year for healthcare. This would add 10%, 40% system-wide deployment in US.
Okay. Great question. No, there have not been any cost estimates. What I can say is that ransomware is incredibly expensive. So I mentioned, Change Healthcare was a ransomware attack that really impacted a lot of the back-end billing systems of the United States healthcare system earlier in this year. The ransom alone was $22 million. The Scripps ransomware attack that lasted a month, the board minutes state that it cost Scripps $120 million for their ransomware attack. Now, your cost question is a great one, but there's also tremendous cost with these ransomware attacks, and a lot of that has to do with human cost as well. We didn't show, but we've published a paper earlier this year that showed if you have a cardiac arrest in an area that is having a ransomware attack, your survivability with favorable neurologic outcome goes down tenfold. So when we calculate the impact, not just financially with paying ransoms and delayed care, et cetera, but also the human cost of this, it is a huge expense. Now, if we strategically placed this technology at various parts of this country and could deploy it rapidly, I bet the ROI would be easy to justify. I don't think that every hospital should invest in redundant systems to do this. That would increase the cost of healthcare, 8%, 10%, which would be not how we should approach this. Instead, we should be smart and strategically place these things across the country so that we don't have to buy every hospital a backup system. Just some of the hospitals, because they'll be ransomed at different intervals.
Quick question.
Hi, my name's Nimit. I'm a third-year med student here at UCSD. My question is actually very similar to that in terms of cost, but more so from the perspective of hospitals that haven't been impacted by these ransomware attacks. Do you find that they are very open to planning in advance, or is that something that regulations needed to push them and incentivize them, or even external sources like insurance companies to maybe monetarily incentivize them to be more preventative?
That's a great question. We've been doing this work for about 10 to 12 years, and I will say that we have had a significant increase in the number of C-suite hospital boards who do not need to be convinced that this is one of their primary, if not their primary existential threat. Here at UCSD, I think it's relatively public knowledge that a cybersecurity incident is number one on our hazard vulnerability assessment for our institution. So you don't have to get buy-in from that standpoint. And I think the question right now, and some of the way in which our research can be helpful, is like, what do we do about it? What are the practical interventions that are cost efficient, but also do change the impacts that we're seeing on the other end of our research? And so there are some proposals put forward. Senator Wyden and Warner a couple weeks ago put forward a proposal for minimum cybersecurity standards and a significant amount of funding to help hospitals kind of get up to and reach that point. So I would say that we are in the acknowledging that this is a problem phase and figuring out how to best address it.
Thank you very much.
Thanks very much.